Thank you everybody for joining us today. We are going to talk about Macra and the Quality Payment Program. My name is Jason Feltz. I am a practice advisor here at OFMQ. For those of you that aren't familiar with OFMQ, we are a not-for-profit consulting company dedicated to advancing healthcare quality. Since 1972, we've been a trusted resource through collaborative partnerships and a hands-on support to healthcare communities. OFMQ has a number of areas of expertise. Again, we've been around for over 40 years. We work in a lot of different fields, helping out with analytics, case review, education, HIPAA, IT consulting, health IT, national quality measures, and quality improvement. A little bit about myself. I've been in the healthcare industry for over 8 years now. I got my start in a small rural healthcare practice helping with EHR implementation and go live, and then came to OFMQ and work with hospitals and physicians on multiple different quality payment programs and EHR incentive programs. We help out with workflow redesign, privacy and security, and a lot of other health IT matters. So today we're going to cover what Macra and value-based care are, who this affects, when these changes take place, what are the participation options under Macra, and then what are kind of the next steps that you need to put in place to get ready for all these changes that are coming. So CMS value-based programs are new programs that are designed to reward healthcare providers for quality of care over the quantity of patients that they see. It's really part of a larger strategy to reform our current healthcare system. The three-part aim for these value-based programs is to provide better care for individuals, have better health for our populations, and lower healthcare costs. So Macra is kind of the new hot topic value-based program that is being rolled out. The Medicare Access and CHIP Reauthorization Act of 2015 was signed into law April of that year. What everybody is a little bit more familiar with is the new Notice of Proposed Rulemaking that came out. This was released in April of 2016 and pertains to really a lot of the health IT portions of the Macra rule. We have a final ruling expected by November 1st of 2016, so everything that we go over in this presentation is just proposed, so some of these things could change with that final ruling, although we expect a lot of the things to stay in place. So this Macra program introduces a new quality payment program. This is really a shift away from fee-for-service and the start of value-based payments for healthcare. So Macra is going to repeal the sustainable growth rate formula, which factors into the fee-for-service model. And they're also going to streamline quality reporting programs. So they're taking meaningful use, PQRS, your value modifier program, and putting them under one big umbrella. So under this new quality payment program, within Macra, you're going to have two different pathways for participation. The first one is called the Merit-Based Incentive Payment System, or MIPS, and the second one is Advanced Alternative Payment Models, or APMs. First we'll get into MIPS and all the different requirements, and then we'll talk about a little bit later about the Advanced Alternative Payment Models and some things that you could do to actually be excluded for MIPS and participate in different ways. So the first one, the Merit-Based Incentive Payment System, is the pathway that the majority of providers under this Macra program will most likely participate. Eligible clinicians under MIPS include physicians. This is going to be DOs, MDs, dentists. It also includes your mid-level providers like PAs, nurse practitioners, clinical nurse specialists, and certified registered nurse anesthetists. They have plans to include other clinicians in the future, like physical therapists, occupational therapists, registered dietitians. Although they aren't going to include those additional clinicians until further years in the program. So for 2017, the ones listed above will be included for participation. Under the MIPS program, you can choose to report as an individual or as a group. The groups will be defined by providers practicing under the same tax identification number. If you do report as a group, you will have to report as a group across all 4 performance categories, so it's not kind of a pick and choose, it's a all or nothing, and that will be the average of all the providers within that group is the score that will be reported for that organization. There are a few exemptions from MIPS, so newly Medicare enrolled clinicians. So for the first year that you are billing under Part B of Medicare, you would be excluded for MIPS participation. So that's nothing you have to go and apply for. That's just automatically put into place for those newly practicing docs. Clinicians that have a low patient volume threshold of Medicare patients, so if you have less than 100 Medicare patients in the course of a year, or your total allowable charges are less than $10,000 for the year, then you can be excluded from MIPS as well. So that will probably apply to some of you out there that are pediatricians or maybe some other specialties that see low Medicare volumes. And then certain participants in advanced APMs, so again that was the other big pathway under the Macra umbrella, and we'll talk about that a little later in the presentation. And then I just want to touch on the fact that MIPS only applies to individual clinicians. It does not apply to hospitals or facilities. So federally qualified health centers, rural health clinics, hospitals are all exempt from MIPS. With that said, there may be some providers that practice in hospitals or FQHCs that could still be eligible for MIPS based on the way that they bill. So if you have any questions about that, reach out to us or check with CMS on your eligibility. The payment adjustments under the MIPS program will begin in 2019, so your first year of participation will be 2017, and then those payment adjustments are going to kick in 2 years later. The payment adjustments in 2019 are actually going to vary based on your participation. This is something we'll get to in just a second, but there's a new option to choose different pathways of participation for your first year. But as we move forward in the program to 2020 and onward, you can see that that incentive or reduction in payment is going to increase up to 9% further on in the program. So this is again going to be based on your composite score across all of the MIPS categories. So just earlier this week, CMS came out with an update, and it's a pick your pace option for the quality payment program in 2017. Your first option would be to just test the quality payment program. Under this option, you would receive a neutral payment adjustment, so that means you would not be penalized. Under this, you would basically just report on MIPS. Even if you don't meet the thresholds, you're still not going to be penalized. Your second option is to participate for part of the calendar year. We won't know until the final rule comes out, so this could be maybe a quarter or just half of the year, but if you participate for part of the year and meet the thresholds associated, then you will receive a small positive payment adjustment. If you participate for the full calendar year, you'll receive what they're calling a modest positive payment adjustment. My assumption would be that that's probably around the 4% initial incentive that was in place for the 2017 reporting year, 2019 payment year. And then your fourth option would be participation in one of the advanced alternative payment models. So in MIPS, there's 4 different performance categories that you'll be scored on. Again, under this new program, they're taking meaningful use PQRS and the value modifier program and rolling them all into one. Your new performance categories under MIPS are going to be quality, cost or resource use, clinical practice improvement activities, and advancing care information. In year one, these are the weights that are going to be assigned to each category. So quality will be 50% of your total score, advancing care information 25%, 15% for clinical practice improvement activities, and 10% for cost. These sections and weights can change as the years go on. So as the program continues and CMS focus changes, you'll see the percentages for these categories continue to change as well. The first category we're going to discuss is quality. Again, this is your biggest category in year one. It's 50% of your total score. This category really is going to be what replaces PQRS reporting. Eligible clinicians under MIPS will select 6 different quality measures to report on. You'll have to include one cross-cutting measure and one outcome measure. These are kind of new terms or classification that are going to differ from the old national strategy quality domains that you saw under PQRS. You'll also be able to select from individual measures, or they'll have specialty measure sets set up for you. The proposed quality measures are also going to change from year to year, or could possibly change throughout the program. Whenever these measures do change, or they add or remove measures from the list, they will have to update this process in the Federal Register. They'll post that information by November of each year, so that you and the EHR vendors will be able to get those reports in place for reporting under the MIPS program. The second category that makes up your score is cost. This is 10% of your total score in year one. It's also known as resource use. This is going to replace the cost component from the existing value modifier program. A kind of good and maybe bad thing about the cost is that there's no reporting that's going to be involved. It's completely based on Medicare claims. So the good news is you don't have to report anything. The bad news is it's just pulled from claims data, so you're not going to have any influence on that information. You're going to be rewarded for more efficient, high-quality care. They're going to look at 40 plus episode-specific measures to account for different specialties. Some things that they're going to look at are your combined spending on hospitalized patients, and also the amount that is spent on patients for primary care services. So they'll look at different conditions, the amount of spending on healthcare that was spent on that condition, how it varies based on different providers, and then your score in this category will be adjusted accordingly. Again, this is only 10% in 2017, but this component will increase as the program goes on. So make sure that you get familiar with the way that they are adjusting these cost categories. The third section is clinical practice improvement activities. This is going to be 15% of your MIPS score in the first year. Clinicians are going to be rewarded for different activities that they engage in. Some different topics are care coordination, patient engagement, and patient safety. You're going to have a list of more than 90 different options to choose from. They'll be categorized differently, higher, medium, and be weighted differently as well. So you achieve full credit with 60 points in this category. This category also, you can receive credit if you are part of an existing alternative payment model. So these are going to be your traditional models like a patient-centered medical home, the shared savings programs, or accountable care organization participation. So if you're participating in any of those current activities, you can receive at least half or up to full credit in this section of MIPS for participation. So that is something to look into. If you're not participating in any of those models currently, you'll be able to select from this list that is going to have a lot of different activities that are similar to what they're doing in some of the current alternative payment models. The fourth and final section that makes up your MIPS score is advancing care information. This is going to be a quarter of your total score in the first year. This is really the new meaningful use. They had to make it a little bit more complicated and change the name on us, so just another acronym that we get to learn. But this is going to be your EHR reporting section of MIPS, and it aligns with the proposed Stage 3 meaningful use. For clinicians who are, the objectives are not applicable, so maybe hospital-based physicians, those are going to be ones who see 90% or more of their patients in the inpatient or ED. You would not have to report on this section. If you don't have to report on this section of MIPS, the other categories will be reweighted to make up for that. So in the advancing care information, what they're trying to do is get away from some of the hurdles or roadblocks that we came up against in meaningful use, and focus more on outcomes and promoting innovation. And interoperability is still a really big key under this advancing care information. So they want to reward providers for outcomes that technology helps them achieve with patients. So instead of just giving you a list of technology that you have to in place, you'll be rewarded for having different options and different ways of communicating with patients or allowing them to access their medical information. They're going to allow flexibility with health IT, so within the new certification program, they've gotten away from complete certification, and now it's more of a modular certification. So you can be certified to do all of this stuff under MIPS, or maybe just a certain little part or a new app that could help out and allow providers a new way of interacting with patients. And again, prioritizing interoperability, so a focus on real-world applications. We know that there's been a lot of headaches with direct messaging and the ways that EHRs currently calculate how well you're doing with interoperability. So under the advancing care information, they're going to expand on that and find new ways to see how providers can really communicate and improve on coordination of care. So your ACI scoring is going to be made up of a couple different factors. You're going to have your base score, which is worth 50 points. The performance score is worth 80 points, and then you can also receive bonus points. As long as you receive 100 points or more, you'll get your full credit for the ACI category. There's 131 points available when you combine all of these different elements. So as long as you get 100 points, you receive full credit though. So your base score, which accounts for 50 points, this is going to be your traditional numerator, denominator, yes-no objectives like you're used to with meaningful use. There's only 6 proposed objectives under this base score category. So you're no longer going to have to report on clinical decision support or CPOE. And the only reporting required to public health agencies is going to be immunization reporting. So you'll no longer be required to do the cancer reporting, but that's where you can go back and pick up those additional bonus points by connecting to other clinical data registries or public health registries that are available in your area. So these are the 6 objectives that you will have to attest to to make up your base score. Protect patient health information, so that's going to be completing a security risk analysis, which you should already be doing for HIPAA every year. Electronic prescribing, patient electronic access, coordination of care through patient engagement, health information exchange, and then your public health and clinical data registry reporting. So as long as you report on these 6, then you will meet your base score for the ACI category. That will kind of get you to where you're close to that neutral payment adjustment, so you won't be getting penalized. And then the next category, your performance score, is where you can earn additional points to receive incentives through the MIPS program. So your performance score is going to account for up to 80 points. 3 of the different measures, or 3 of the different objectives are going to have multiple measures beneath them. And so depending on how well you do in these categories will determine your performance score. So the first one is patient electronic access. Within that we have patient access. That's going to be providing patients online access through a personal health record or patient portal. And then providing them access online to patient education tools. So they just need access about a medication or a condition that they may have, and that information needs to be available online. The second objective is coordination of care through patient engagement. Under this we have three different measures. The first is view, download, transmit. This is going to be patients actually getting in and logging into your patient portal and doing something online instead of just making it available to them. The second one is secure messaging. So this again could occur through a patient portal or through a new health app, just as long as you have a HIPAA compliant, secure way to communicate electronically with patients. And then the third measure within this category is patient-generated health data. And so again, this is going to be some of the new technologies you see where patients can incorporate things like blood pressure logs or maybe dietary information that they're doing or collecting on their own outside of the office, and being able to incorporate that information into their medical record. The final objective that's going to make up your performance score also has three measures as well. Exchange information with other clinicians. So this is again getting back to that interoperability topic. Exchanging information with patients, and then clinical information reconciliation. So in the past we've had medication reconciliation. Under the new ACI objectives they'll be building on that. So you'll probably have to reconcile allergy information, maybe other clinical history stuff as well. So this again is just a chart. So on the left you've got your 6 different advancing care information objectives, and then on the right it lists all of the measures that are associated with each objective. So by reporting on all of the objectives on the left, you'll meet your base score, and then the last 3 on the right, doing better in those categories is going to improve your score and get you more points to earn incentives through MIPS. Data and technology. So there's going to be some changes in the first participation year depending on what version of your EHR you have in place. So the 2014 certified edition is what most people are currently on. This is the certification criteria to meet all of the modified stage 2 objectives under the Meaningful Use program. If you are still using this version of your EHR in 2017, then you will continue to attest to the modified stage 2 meaningful use objectives instead of doing the new ACI objectives under MIPS. If you're using the new 2015 certified edition, which the regulations were just released earlier this year, so I think within the next probably 6 months you'll see a lot of vendors rolling out a new version. Once you're on that new version, you can choose to attest to the old modified stage 2 meaningful use, or you can do the new advancing care information objectives under MIPS. So if you're on the older version, you have to do the old stage 2 stuff. If you're on the new version, then you get the choice of doing the new objectives or old modified stage 2. And then just to note, 2018 is when it will be required that your EHR is upgraded to the 2015 edition. So just make sure whichever pick your pace option you choose for 2017, make sure you have in place plans to get that EHR updated before 2018. Again, sticking with the ACI objectives, focusing on mid-levels though. For 2017, it is optional for mid-level providers to participate in the Advancing Care Information section of MIPS. So they were not listed under the original Medicare program as eligible providers, only the Medicaid, and they've had low reporting numbers in the past, which is why they did not make it a requirement for mid-levels. If you choose to not report, then your sections will be re-weighted, just like with your hospital-based providers. But if you choose to go ahead and attest, then you will be counted just like other providers. So here is a graph that will just show you if you choose not to participate in advancing care information, then that whole section is just removed, and your composite score is only going to be made up of the 3 categories instead of 4. So just to summarize your MIPS total score, again, quality is going to make up 50%, ACI 25, clinical practice improvement activities 15, and cost 10. So if you decide not to do that advancing care information category, then that whole row would be wiped out right there. How do you submit data for MIPS? Again, you can report as a group or an individual. If you report a group, it's going to be an average of all of your providers across all 4 performance categories. For your resource use category or your cost category, that again comes off of administrative claims data, so you're not going to have to attest for that category. For the other 3 categories, there unfortunately are still going to be multiple submission methods. Some of it may be online and manually entering data on a website. Some of it you may be able to generate and send directly from your EHR. Some of it may have to go through qualified registries. So there are going to be a variety of submission options for the quality ACI and clinical practice improvement activities categories. The plan is, since all of these programs are getting put under one roof, that this process will eventually get streamlined and be housed under one system. I'm not sure that's going to be the case for 2017, but again, when that final rule comes out by November 1st, we should know more. I also want to touch on the Medicaid EHR incentive program while we're talking about the ACI category. So Medicaid program is still going on. You can still earn incentives through that program by participating. 2016, this year, is the last year to begin receiving an incentive payment under Medicaid. But that program does continue on until 2021. So say you've been participating in the Medicaid program up until now. Next year you're going to have to start participating under Macra, but you still have incentive money left. You will have to dually report. So you'll have to report your meaningful use data to Medicaid, and then you'll have to report your MIPS information to Medicare. So the good news is that incentive money is still there. It's not going to be taken away. You can still get it through 2021. The bad news is you will have to report separately for both programs. So when do these proposed changes take effect? Again, 2017 is when you will start collecting data under the MIPS program. So it will no longer be meaningful use in PQRS next year. This year is the last year for those 2 programs. In 2018, they are going to sunset the meaningful use in PQRS payment adjustments. And then in 2019 is when the new payment adjustments under MIPS will take effect. Again, this only affects Medicare eligible clinicians. It does not affect hospitals, doesn't affect the Medicaid EHR incentive program, or other facilities like FQHCs. This graph is a timeline that just shows you how these different programs align and play out over time. So the top row there is your fee for schedule updates, and you can see that begins to phase out in after 2019. Your MIPS, again, you'll begin collecting data under in 2017, and then you can see how the payment adjustments start in 2019 and continue to increase as we go. And then this last section here is the advanced APMs. So if you qualify for one of these programs, you can be exempt from MIPS and participate under that program instead. So we'll jump into the advanced APMs, which again is the second participation option under the big Macra umbrella. So just quickly to clarify traditional versus advanced APMs. Traditional APMs are ways that CMS has started paying healthcare providers for the care that they give. Some examples include accountable care organizations, patient-centered medical home, and bundled payment models. Participation under these existing models may fulfill a portion of your MIPS score. So again, we talked about the clinical practice improvement activity portion of MIPS. If you participate in one of these traditional models, that can count as part of your score under that, but it does not exclude you from MIPS altogether. Advanced APMs, on the other hand, are models or programs in which the clinicians accept both risk and reward for providing coordinated, high quality, and efficient care. Um, these models also are fundamentally founded on quality measurement and the use of EHRs. So even if you participate in one of these instead of MIPS, you're still going to need that EHR technology in place. Clinicians who participate to a certain extent can be exempt from the MIPS payments and qualify for that 5% Medicare Part B incentive payment. It's important to note that to be excluded, you have to see enough of your patient volume through that advanced alternative payment model. So you will need to be fully participating in these models to avoid having to participate in MIPS as well. This right here is a list of the currently approved APMs, advanced APMs by CMS. There's only 6 that are approved for 2017. CMS will continue to update this list annually and add new payment models as they come out and get approved under CMS. I will talk briefly about one of these models, the CPC Plus, Comprehensive Primary Care Plus. Here in Oklahoma, we were one of 14 regions that were selected for participation under this model. So CPC Plus is a national advanced primary care medical home model. They want to strengthen primary care through multi-payer payment reform and transforming the way that we deliver care. There's 2 different tracks to participate in, and this is a 5-year model that begins January of 2017. So the deadline to register for this track is September 15th. You do have the option to back out and choose to participate in MIPS instead before January, but you do have to go ahead and sign up by the 15th if this is something you're interested in. So CPC Plus has a couple of different payment elements. Again, it's a multi-payer collaborative, but within CPC Plus under the Medicare side, you're going to have a care management fee. This is a non-visit based fee. It's paid per Medicare beneficiary per month, and the amount is going to be risk adjusted to account for the intensity of care management. So CMS will classify your Medicare patients in different tiers, and that's how they're going to risk adjust your score. And this care management fee is paid on a quarterly basis. The second payment element within CPC Plus for Medicare is a performance-based incentive. So this incentive is paid up front and then will either get to be kept or recouped, either all or in part, depending on how you do on patient experience measures, clinical quality measures, and utilization measures that drive the cost of care. So again, that's paid prospectively and then will get reconciled at the end. So if you do really great on all the reports, then you get to keep that full incentive. If you maybe didn't do so well, then some of that incentive is at risk of being recouped. The third payment element under CPC Plus is going to differ depending on which track you choose. If you're in track 1, you'll continue normal Medicare fee-for-service payments. If you're in track 2, you'll have a reduced fee-for-service amount. So you'll be on kind of a hybrid program to where a percentage of your fee-for-service payments will remain, but the other percent will be replaced by an additional quality incentive payment. So here within Oklahoma, the additional provisional payer partners outside of Medicare are the Advantage Medicare Plan, Community Care, Blue Cross Blue Shield, Medicaid, and United Healthcare. So all of these different organizations have entered into a memorandum of understanding with Medicare. CMS has issued guidance and said that if you have questions as to the level of participation or the incentives available through these different payers, that you're going to have to reach out to them individually. So they will probably not amount to the incentives that Medicare is offering, but there could be some significant incentives from other commercial payers to participate in CPC Plus as well. This right here is the eligibility criteria for CPC Plus. So if you're in track 1, they're going to need some demographic information. You're going to have to show them that you're using a certified EHR. A sufficient revenue has to be generated through Medicare and those other list of payers. So at least 50% of your claims need to run through that list of payers here in Oklahoma. And then you have to attest to the fact that you're gonna that you already participate in some of these care delivery activities. So you're going to have to already assign your patients to a provider panel. You're going to have to provide 24/7 access to a healthcare provider or their care team for your patients. You're also going to have to agree to support these different quality improvement activities under the program. If you want to do track 2, which is going to be a lot more intense, but there are, again, additional incentives under track 2 as compared to track 1. You're going to have to say that you're doing everything track 1's doing, plus a few other things like developing and recording care plans, following up after ED or hospital discharge, so a lot of that coordination of care stuff needs to already be in place. And then implement processes to link patients to community-based resources. So in track 2, there's a lot of focus on behavioral health elements. So making sure that either you provide that information and services to the patients or that you have them linked up to someone in the community that they can go to for those needs. With track 2, you'll also need a letter of support from your health IT vendor outlining their commitment to the program. The reason is there's additional certification criteria that is required for participation under track 2. So you need to make sure beforehand that your EHR is going to be able to, or is actually looking into participating and going to have those additional features available for you if you want to do the CPC Plus program. So for application, you are going to apply directly for whichever track you're interested in, track 1 or track 2. CMS can decide to bump you down to track 1 if they don't think you're ready for track 2 based on your application. So just know that is a possibility. And then there's a link here to the online application portal as well. So again, that was an overview of CPC Plus. It is one of the 6 approved advanced alternative payment models in place for 2017. So what you got to do next to get ready is decide if you qualify and are going to participate in one of those advanced APMs or if you're going to participate under the MIPS program. If you are going to do the MIPS program, then you're going to have to pick your pace. Again, you can choose just to report, doesn't matter how good you do, and not get penalized. Or you can report and meet all of the thresholds for part or all of the year and qualify for some incentive money that would kick in 2019. And then you also need to decide if you're going to do group or individual reporting. So if you have multiple providers under the same tax ID, you may need to assess how your providers have currently been doing under meaningful use in PQRS and see which way will be more beneficial for your organization to report. Begin collecting data in 2017. So if you're going to do all your reporting January 1, you're going to have to start looking at some of these new measures and new categories. And then don't forget to report for 2016. So just because we have all these changes in Macra and MIPS coming up, you're still going to have to report one last time for the 2016 reporting period. So you're going to have to report for meaningful use in PQRS. Meaningful use again this year is the modified stage 2 meaningful use objectives. And there is a link here to the spec sheets that outline those objectives if you need a refresher there. I will also let you know that they have introduced a bill to alter meaningful use in 2016. This would do some things like reduce 2016 to a 90-day reporting period, remove some of the objectives like CPOE and clinical decision support. Unfortunately, we won't know about all this stuff until probably the same time that we have the final rule for MIPS and Macra. So probably October, November, you can expect more information on what the final reporting period for 2016 is going to look like. But just remember, you will have to report that information by the end of February next year. This right here is just a list of acronyms in case you get confused when you're going through all this stuff. So we still have some of the ones in place from previous years and then a lot of changes under this new Macra program. So just to keep you refreshed on all this information. Again, we are here to help at OFMQ. Feel free to jump on our website. We're going to have additional videos coming out every month on a new hot health IT topic. So if you have questions about Macra, MIPS, privacy and security, quality reporting, anything in the healthcare realm, feel free to reach out and we are here to help. Thank you for joining us today, and we look forward to you coming back again next month.